I'm Dr. Sujana Reddy. I'm a third-year internal medicine resident physician at East Alabama Health in the Auburn-Opelika area. I'm also the vice president for Awareness for Potsies and also serve as a medical advisory board leader. I also have POTS, ME/CFS or myalgic encephalomyelitis, chronic fatigue syndrome, mast cell activation syndrome, and Ehlers-Danlos syndrome. And I also am a long hauler.
My name is Mallory Stanislazic. I'm a pediatric nurse practitioner in primary care, although I'm not currently working because I do have POTS. I am a long hauler, so I have POTS due to having long haul. I have mast cell activation syndrome, ME/CFS, and snowy vision syndrome. I am the pediatric advisor for Awareness for Potsies, as well as a board member, and I am the mother of a recovering pediatric long hauler.
Thank you so much for joining us today, and we hope that this mini lecture on postural orthostatic tachycardia syndrome in the pediatric population will be helpful, and that you will learn maybe signs and symptoms to look out for should your child develop this form of dysautonomia. So what is POTS? POTS is a pretty debilitating condition, and unlike what the name suggests, tachycardia, it's much more than just tachycardia. It is an autonomic nervous system disorder. Our nervous system is divided into multiple different categories, and one of that is the autonomic nervous system, which branches out into our fight and flight mode and our rest and digest mode. And what happens in dysautonomia is we have a dysfunction of how that is regulated. And our autonomic nervous system regulates things that are on autopilot, things that are automatic, such as our breathing, our digestion, how our heart rate and blood pressure is regulated. And so when this kind of goes haywire, it can lead to a whole number of issues. So, for example, in a patient that is healthy, normal, who has no dysautonomia, say they are laying down or sitting and stand up, the body senses this change in gravity and is able to bring the blood back to the heart. But in patients that have POTS, our blood cannot get back to the heart properly. There's a decrease venous return or blood flow to the heart because there is a lack of that function, and therefore blood to the brain also gets affected, and that can lead to a whole host of symptoms that I will be going through on the next two slides. There's a wide array of symptoms, but we'll be talking about some of the most common ones that someone with dysautonomia or POTS might experience. So cardiac symptoms are typically the most common just because our body tries to adapt and compensate for that change. And so patients might feel like their heart is racing. They'll have these heart palpitations, chest pain, shortness of breath, or dyspnea. They might get very lightheaded if they stand up too quickly, and that's pre-syncopal, feeling like they're going to pass out. Some individuals actually do pass out. I can count on my hand, though, how many times I've passed out in the last 3 years. And so it's not very common, but it can happen. Exercise intolerance. Because our cardiac output is very poor because of the decreased venous return and all the blood pooling in our legs, exercising and cardiac aerobic exercise is going to be very difficult. And so a lot of us do have exercise intolerance and get very, very chronically fatigued, even doing simple things such as walking to the bathroom or getting up out of bed or brushing your teeth. Like simple things just become very tedious tasks. GI symptoms are also very common because blood pooling can just kind of stay localized in the abdomen, and then that can affect how digestion occurs, how all the processes and enzymes work in the gut. And so patients might feel nauseous and bloating. They get abdominal pain. They might get changes in their bowel habits, diarrhea, constipation. Furthermore, because we're in this fight and flight mode, a lot of patients also feel on edge. They feel maybe shaky. They'll get muscle pains, joint pains, feel a little anxious too, right? If you're kind of in that mode where you're like running away from a tiger and bear all the time, you're going to feel kind of jittery. And that leads to also trouble sleeping. It's hard to kind of shut that system off once it's activated. And so a lot of patients complain of insomnia, temperature dysregulation. Some people might get really, really cold, their feet, their hands, because of the blood pooling. You might see some acrocyanosis or reddish purplish discoloration in the extremities. People, because of lack of blood flow to the brain, they get vision changes, blurry vision, migraines, really bad occipital or back of the head migraines, brain fog, which I don't think brain fog really does justice to kind of how severe those symptoms might be, because you can imagine if you're not getting blood flow to your brain, it can affect how everything's firing, how you're processing things. We have a lot of memory deficits, short-term memory. They might just seem forgetful, almost like easily distracted, like they have attention deficit disorder, ADHD, or even if your child has ADHD and they're on medication like Ritalin or Adderall, and those medicines may not be working if they have dysautonomia. Also menstrual changes. I mean, I could go on and on about menstrual changes, but hormones and POTS kind of go hand in hand. Oftentimes in young females, they'll say, I feel worse when I'm ovulating, or I feel worse when I'm on my cycle. Co-occurring conditions that can occur with POTS, like mast cell activation syndrome, and how it plays a role with hormones such as estrogen and progesterone. So what is the diagnostic criteria for POTS? There is a long, long debate about this, and there's really not that much research in children below the age of 12. So the criteria that we do have is from 12 years to 19 years, and I'll go through the 5 components here. The first criteria, we do the NASA lean test or the stand-up test if your facility has the head-up tilt test, the table tilt test, which is performed usually by electrophysiologists or cardiologists. They will lay the patient down at rest, check their heart rate, their blood pressure, and then stand them up, usually check vitals, including heart rate and blood pressure, 1 minute, 3 minute, 5 minute, up until 10 minutes. And if, say, the baseline heart rate laying down is 60 and your child's heart rate goes up 40 beats from 60 to like maybe 100, 102, 105, just giving an example here, then they meet maybe one of the criterias. The other thing is you cannot have orthostatic hypotension. So when you're doing this test, you cannot have a drop in your blood pressure, and that's defined as a drop in systolic of 20 millimeters per mercury and or a diastolic drop of 10 millimeters per mercury. Oftentimes during this test, patients will get very symptomatic. When you stand them up, they'll feel dizzy, they'll have heart palpitations, chest pain, they'll feel shaky. I actually just recently did this on one of my patients in the hospital who was 18 years old. And when I stood her up within 2 minutes, I had to lay her back down because she had all of these symptoms, blurry vision, felt like she was going to throw up, her hands went numb, feet went numb. And so having symptoms during the test is also part of the criteria. The fourth criteria is experiencing these symptoms at least 3 months. And you have to also exclude or rule out any other explanations of sinus tachycardia, anemia, fever, any sort of infection if your patient's dehydrated, any thyroid issues like hypothyroidism. Pheochromocytoma is not that common, but it also does need to be ruled out. It's a benign tumor of the adrenal gland that can secrete hormones that can kind of mimic POTS. Also, if your patient's on any medications that might stimulate sort of sympathetic overdrive, any cardioactive drugs, caffeine products too, for example, anxiety disorders, anorexia, hyperventilation, and or if your patient is severely deconditioned, like prolonged bed rest, that can mimic some of these symptoms. So you have to rule all of that out. And basically, this is a diagnosis of exclusion. So POTS has always been around, even before COVID. So It mainly, through the literature that Mallory and I have read, it typically affects Caucasian teenage females that are going through puberty, who have hit a growth spurt or are about to start their cycle, menarche, the first cycle, or post-menarchal stage, starting their menstrual cycle, because hormones are heavily involved in kind of triggering dysautonomia. There's a lot of reasons for that could be a whole lecture in itself. Co-occurring conditions like Ehlers-Danlos syndrome, autoimmune conditions such as lupus, Sjogren's syndrome, multiple sclerosis. I mean, those are just a couple of examples, but diabetes. So people that have those conditions often have a higher chance of developing POTS. Also, POTS patients tend to be high achieving, either academically or athletically. We just have noticed that in the literature that we've read, and also associated with other triggers. So not just COVID, like I mentioned, infections such as the flu, post-concussion syndromes, trauma, surgery, vaccinations. All of these are adjuvants or triggers that can lead to or be associated with onset of POTS. So in COVID, we've seen an increased number of dysautonomia just because the pandemic has hit such a wide population. But in the pediatric world, especially during early on, like alpha strain, beta strain, delta strain, we at first didn't think children were really that affected because we were only seeing severe hospitalizations in, adults. But as the strain went on and became Omicron, we saw that it was affecting children as well. And they were getting more severe disease. And I will briefly mention multi-system inflammatory syndrome in children, or MISC, which is a rare condition. It affects 0.01% of children, where they have sort of an inflammatory state that affects their entire body, and 68% of those actually have to go into ICU admission. At least anecdotally, from what I've seen, observation-wise, again, there's no literature on this, digging into it, but children that have had that severe form, a complication of acute COVID infection, do seem to have more long-term issues, long COVID, and also dysautonomia, at least from pediatricians that I've talked to, and family medicine physicians that deal with this population. This study by Lopez et al. Looked at as a systematic meta-analysis of the pediatric and adolescent population, and it found about 40 common symptoms in this population, and about 25.24% of these patients had one or more of these 40 symptoms and had long COVID. So you can see it is hitting a lot of the things that we've already talked about: fatigue, dizziness, balance issues, orthostatic intolerance, exercise intolerance. All of these manifest right in dysautonomia, and it is something that still needs to be researched.
So sometimes when your child will go through all the testing for POTS, you'll find out that they don't quite meet the criteria. So you'll go through the tilt table test, or you'll do the Nasoline, and you'll find out that they do have the blood pressure drop that Dr. Reddy was talking about in 2 slides prior. You might end up feeling a little frustrated, like they have so many of these symptoms, but now I'm being told they don't meet the criteria for POTS. Because when you've got a child going through all of this, you want answers, right? What do you do when you've got a child with all of these symptoms, but they don't quite fit the box? The good news is there are other dysautonomias, and there's other syndromes out there. That's good and bad news. So there's other types of autonomic dysfunction. So there's things like orthostatic hypotension, where when you stand up, your body drops its blood pressure. So we talked about one of the criteria for POTS is that you don't have orthostatic hypotension. So it may be that in doing those tests, we find out that your child does have that drop in blood pressure. There's orthostatic tachycardia. There's vasovagal syncope. So if your child goes through these tests and you find out that they, for whatever reason, they don't quite fit the criteria for POTS, try not to lose hope, because there may be other options that need to be explored. Not everybody's going to fit that box properly. And what I'm going to encourage you to do is to really meet with your provider and kind of dig through what that means. Why don't they meet the criteria for POTS, and what is it that's different? A lot of these syndromes, ME/CFS, MCAS, all of them have a lot of similar symptoms with like one feature that kind of stands out that's a little different. So you might find that they tend to have more ME/CFS features, and they're not having as much of, the tachycardia isn't as big of their problem as much as PEM or post-exertional malaise. And so really you need to go down more that ME/CFS path. And a lot of times these things will all overlap and they can have POTS and ME/CFS. So just because you get a POTS diagnosis, if you're starting to notice some post-exertional malaise, don't rule out ME/CFS just because they have POTS. Unfortunately, a lot of these things will co-occur together. So that's the other thing we wanted to mention, is that you will see some of these things happen together. And I get a lot of questions on my Instagram. I do run this a long COVID NP Instagram, and I get a lot of questions from people about like, how do I tell the difference between POTS and ME/CFS? And it gets difficult. The water gets really muddied because a lot of the symptoms are very similar, and they share a lot of the same symptoms. And then there's that one there's that one symptom that kind of stands out from the other, that with POTS, tachycardia is the big symptom, and with ME/CFS it's that PEM factor. With MCAS it's that more allergic, like hives, idiopathic anaphylaxis kind of thing going on that tends to bring you towards that path. So it's just these kinds of things that you're going to have to really dig through with your provider to help figure these puzzles out for your child. But all of this is really, really tough when you're dealing with kids, especially kids of different ages. Kids don't present like adults. There's this myth that tends to go around that kids are just tiny adults, and kids' bodies are going to work the way adults' bodies work, and that's not at all true. Kids' bodies develop, and at different stages in their lifespan, they develop at different rates. Kids have different needs at different times in their childhood. So this gets really tricky in pediatrics. And there's some questions you're going to need to ask yourself that are going to be helpful before you go to your appointments. So we've compiled a list of questions, things like, how does my child act compared before they got sick? What are they no longer able to do? And when you're looking at younger kids, especially like toddlers, how do they compare to their friends or their peers? For really young kids, are they able to keep up with other kids their age? Is my toddler not running around playing? Are they lying down on the playground when their friends are running around? Are they getting tired more easily? How long has my child been acting differently? And how long after the infection did it start? Like, is this something that we should be, correlating with an infection, or should we be correlating it with something else? Is this days, weeks, months? This is about long COVID. Long COVID can take a couple months to present. So, that's where this gets tricky. A lot of people are like, oh, well, we had COVID a couple months ago. The criteria for long COVID now is about 3 months. Because it can take that long. POTS, they say you need to be having these symptoms for 3 months. It used to be 6 months. They shortened it for 3 months, because I want to start catching these diagnoses earlier. But take a little longer. Originally people were like, oh, long COVID happens right after the infection, but now we're noticing you can have gaps from the infection to when you start noticing these symptoms. So these are things to also be thinking about. Your child doesn't have to get sick and then immediately have these symptoms. So that's something always to keep in the back of your mind as well. Does my child perk up or feel better after a good night's sleep? That's a good thing to kind of keep an eye about, does a nap really help them? What makes my child better and what makes my child feel worse. These are good things to kind of keep an eye on. These will help give your provider clues to kind of what's going on with your child. What symptoms keep my child from doing what he or she needs or wants to do? What does my child seem to have trouble remembering or focusing on tasks? This is a big one. A lot of kids will start getting this like bad kid rap. You'll start having a lot more trouble at home. There'll be the kid who's all of a sudden like not doing things, and there'll be more behavioral problems at home. And it'll seem like your kid's not doing things on purpose, but it may actually be brain fog. And they may not actually be the bad kid, or they may not actually be giving you as much attitude as you think. It may actually be that they're struggling. And that brain fog, like Dr. Reddy talked about, is that that short-term kind of memory brain fog thing that can happen with POTS. If you're not getting enough blood to your brain, multiple sensory stuff can be really hard. And so if the TV's on and you're talking to your kid, multiple sensory happening all at once, it may be hard for them to remember what they're hearing. And it may be you ask them to do something and it just doesn't compute. And to you, you're thinking, you feel ignored, you get upset, but to them, it really just didn't compute in their brain. They're struggling with the multiple sensory issue. And it becomes a family fight. Does my child complain about feeling dizzy, lightheaded? Younger kids, they're not gonna walk up to you. Your toddler's not gonna walk up and be like, I'm dizzy. They may complain of being like rocking, feeling like they're on a boat. Or they may not even say that at all, but you might find that they're a lot more clumsy all of a sudden. They're dropping things more easily. Again, with toddlers, that's a really hard thing to determine. Toddlers are clumsy by nature. But if there all of a sudden is a significant change in their ability to do what they were able to do before, that's a red flag. Do you seem to have more behavioral issues like we were just talking about? Kids with ADHD are higher risk for long COVID. So are you having issues with kids who were on ADHD medications and they were well managed, and all of a sudden they're not managed now well anymore? This is, again, that brain fog issue, something you want to keep an eye on. Can my child still participate and enjoy activities that used to be normal for them? This is that exertional issue. So if you have POTS and you used to play soccer and you used to love it, and now you can't, your body's struggling when you're upright to get that blood where it needs to go. You want to run, all your blood is pooling in the bottom. You don't have enough blood to get to your heart to pump it where you want to go. Running on the soccer field is now going to be 10 times harder. Do these activities result in crashes, or for the younger kids, like behavioral problems or tantrums? Because when they want to do something and they push themselves, they're going to be a lot more tired afterwards. Young kids don't know how to process those feelings, those emotions. They're going to have tantrums. So these are all things to look out for. POTS is a syndrome, and the hard things with syndromes are a grouping of symptoms that go together, and we don't know the underlying pathophysiology. We don't know the true underlying cause. And the hard thing with that is when we don't always know the true underlying cause, we don't necessarily have a true treatment. What we do is called symptomatic treatment. So that's a lot of managing the symptoms, but we don't have a treatment at the source. So for POTS, especially in pediatrics, the first line treatment, the first thing we are going to do is called lifestyle management. So we work on increasing water intake and salt intake. And the reason we do this is we want to build up all the fluid in the blood vessels so that when you stand up, there's not as much room for everything to fall to the bottom. So like Dr. Reddy talked about, when you stand up, gravity takes over, all your blood goes to the bottom, it pools to the bottom. There's not much blood up in the brain, around the heart. This is why you feel like you're going to pass out. This is why a lot of our symptoms occur. overload you a little bit with water and salt. So what happens is the salt pulls the fluid into the blood vessels. Then we're going to keep more blood up here. The amount of water and the amount of salt will be individualized based off of your child's symptoms and your child's weight. So that's something you specifically want to talk about with your provider. Other things that we do are physical activity with pacing. So physical activity is something I always like to kind of say with a caveat, because ME/CFS can go along with POTS. And physical activity, the reason we want to do physical activity is as you strengthen those muscles, you can use the muscles to help push the blood back up, especially the leg muscles. We can use the muscles to actually work to push the blood back up in the body. But if you have ME/CFS, physical activity can actually cause post-exertional malaise, including recumbent or lying down activity. So you want to work with a physical therapist who is very well versed in ME/CFS and POTS. And you want to make sure that your child doesn't have ME/CFS before you start doing physical activity kind of on your own or following any of the POTS protocols out there by yourself. So that's kind of my caveat with physical activity. Pacing is this thing that you want to look up things called spoon theory. Pacing is about doing things and managing your energy so that you're not trying to live your life the way you used to and not just burning out everything you have all at once really fast. And the things we do are we wear compression garments, again, kind of that whole, holding, so compression socks, compression pants, things like that, pushing blood back up to the brain. You want to elevate the head of the bed. If you have one of those mattresses that like the hospital beds, you don't want it to go like that. You actually want to put the risers under your bed so that it's an actual elevation like this. And then countermeasures like crossing your legs, tensing your muscles when you're standing. All of these things you'll work on with your child's physical therapist or OT. Now, depending on how well those work for your child, how severe their POTS is, they may need medication management. Again, there's no magic pill for POTS. These medications help manage POTS, help manage the symptoms. There's medications to lower heart rate. There's medications to help increase the amount of blood that stays in the veins. And there's medication to help with constricting the blood vessels to push the blood back up to the heart. But there's no medication to actually treat POTS at the root cause, because we still don't know the root cause of POTS. So many of your children with POTS go to school. And school is a very hard place for kids. So we talked a little bit about pacing earlier. School is the exact opposite of pacing. School is back-to-back classes. School is lots of sensory overload. School is lots of cognitive overload. School can be lots of physical overload. Most schools don't allow water bottles. So you're going to need accommodations in school. You're going to need a doctor's note for water bottle and a doctor's note to allow salty snacks or electrolyte drinks. You're probably going to need an excuse or special accommodation for gym class. You may need accommodations for assignments and extended time for tests, accommodations to allow them to put their feet up, to stand up when they need to sit down when they need to, because sitting for a long time allows for blood pooling, which isn't great. Standing for a long time allows for blood pooling, which isn't great. So they need to be allowed to move around, which oftentimes is not allowed in school. All of these things can be things that you can work on and write. Your doctor can help write a note to write for these accommodations. So as mentioned in the beginning, Doctors Ruddy and I both are on the board and are board members for Awareness for Potsies. Awareness for Potsies is a great support website for patients with POTS. We just wanted to let you know a little bit about it. So this is our website. This is kind of our homepage. It has the Learn About POTS menu down. I also have a great section about living with POTS. You can see it has all information about newly diagnosed, managing, all sorts of information on there. We're adding to the website regularly. large section about being newly diagnosed with POTS. Lots of questions have come up about what does it mean to have POTS. We've come together to try and answer these questions on the website for you. We've come up with what do you need to put in your daily go bag. All of us have POTS. We've come together. What do we put in our go bags? So we've come together with recommendations of what should go into a go bag. We've come up with recommendations of how to prepare for your doctor's appointments ahead of time to help make the most of your short appointments when your doctors only have, 10, 15, 20 minutes to sit with you sometimes. We have a wonderful daily tracker. In fact, some of the doctor's offices are now actually referring patients to our website to use this. So we highly encourage, this is a symptom tracker. So we highly encourage you take a look at this as well. We have lots of information on ways to help manage your POTS. So we talked about hydration and increasing salt. So we have all sorts of recommendations on here. You can see we even link to some of our favorite products on there. You can find all of our favorite products and things that we ourselves actually use. We actually raffle off care packages every month. They're fun things. They have salt, sample, fun little things in there. If you or your child have been having a rough time, I recommend, signing up for a raffle for a care package. The other thing we do is personalized letters. So again, especially if you have a teenager, we're big into mental health, they've been going through a tough time, I recommend, signing up for a personalized letter. We write about 15 letters bi-monthly and try and send them out. We know that getting diagnosed with POTS, living with POTS is something that can be very tough. And so we're trying to be there as emotional support as well. So we are Awareness for Potsies. We're a 501c3 nonprofit organization dedicated to providing POTS and chronic illness community with support, empowerment, education, while pouring as much love into the community as possible. We do not have a pediatric specific section on our website yet. That is something we are in the process of creating. So feel free to please go and peruse our website. There's a lot of really great information on there, and I think you might find it to be a really helpful resource. These are our references. Next slide. And feel free to contact us if you have any questions. Please take a look at our website. I really think it's got a lot of helpful information on there. And I will be available for some question and answers at the end of this presentation. Thank you guys so much for coming and listening.